Welcome to the presentation for Module 9 for the current semester. This is for Nursing 150, Module 9. This presentation will discuss chronic obstructive pulmonary disease and asthma. Some of the problems depicted here in this area right here, in this area right here is talking about the problems that occur with an emphysema and a chronic bronchitis that collectively make up what we know as chronic obstructive pulmonary disease. And the intention of this slide is also to just remind us of the anatomy and physiology of how the bronchioles come down and terminate into the alveoli. First of all, we'll talk about asthma. Asthma is a chronic inflammatory obstructive disease of the airways. As you can see by some of these numbers here, 5,000 emergency room visits each day. That's a huge number. 10.5 million physician office visits each year. This is a fairly big problem in the United States. It can be very serious in some patients. So there's lots of statistics out there that show us that that we have a lot of patients with asthma, and we need to be able to treat them and educate them to kind of hopefully decrease this big number. Look at this number of hospital admissions every day for asthma. So in our country, we do have a lot of patients with asthma, so it's important that nurses understand it and are able to educate patients about prevention of it, maintenance of it, and just help them to understand the disease process so that it can be managed well. Lots more numbers to kind of throw at you here to help you understand how prevalent it is and why it is necessary that nurses be educated about it so that we can help to educate our patients regarding this respiratory disease. The interesting thing about it is we are developing new medications for the maintenance of asthma every day, but despite newer anti-asthmatic drugs, asthma is still responsible for more than 134 million days of restricted activity and about 500,000 hospitalizations annually. Not necessary that you memorize these numbers or anything, but I think it just is a good picture of the population of our country and how many people are fighting this disease on a daily basis. So what is asthma? Let's talk about this a little bit. Although the exact cause of asthma is unknown, we know that it's a chronic inflammatory obstructive disease of the airways. It can occur at any age and may be characterized by wheezing, which indicates like an airway spasm, tightness in the chest, breathlessness, which causes a shortness of breath, and a cough. The severity of asthma can range from highly predictable, maybe a mild attack, to a complete airway obstruction and death. As I said, the exact cause is unknown. There seems to be 3 principal triggers for exacerbations of asthma. So just to kind of summarize this, we know that it's an inflammatory, obstructive disease of the airways. The bronchioles become inflamed. And a lot of times, like I said, there's some 3 principal triggers that we know that cause this inflammation to occur. Allergens and environmental factors are known to be triggers for an asthma attack. It could be molds, pollens, dust, animal, cosmetics, tobacco smoke, some foods, medications, and sometimes aspirin or beta blockers. Those are types of medications that can be a trigger for an asthma attack. Infections. Some people, their triggers are an upper respiratory infection, viral infections, maybe just the common cold. Anything like that can be a trigger for an asthma attack. Some psychological factors, such as stressful events, can be a trigger for someone's asthma attack. Inflammation of the airways is contributed to bronchial hyperactivity. So the key things that I want you to remember about asthma is that it is a chronic condition. It's something that they have all their life typically. It has exacerbations. So this is a reversible problem. So basically what happens is somebody has kind of that reactive airway that we know is asthma. So they have these certain triggers that causes their asthma attack. So if it's somebody, their trigger is the environment, maybe pollen in the environment. So when the seasons change, that's a trigger for them, and that causes that inflammation in the lungs. Once we treat the patient for that inflammation, we have lots of different medications we can use to treat that inflammation. Once we effectively treat it, then the patient's lung capacity and lung function returns to normal. It's only when they encounter these triggers that they have this exacerbation and have this illness. But typically with asthma, it is reversible with proper treatment and management. And that is kind of continued on this slide here, where it is intermittent and reversible. I think those are the key terms to remember about asthma. They occur intermittently when a patient is exposed to the triggers, and typically if it is managed and treated properly with the appropriate medication in a timely manner, it is a reversible airflow obstruction. Key definitions here is that the airway obstruction related to asthma is due to inflammation, and that's inflammation of the bronchioles. So if you think about the bronchioles here, the outside layer, the lumen here, and then inside here is like a mucous membrane. What occurs when a patient with asthma is exposed to their trigger? It may be the environment, it may be a medication, it might be a pet, things like that. Whatever triggers their airway to respond in a hyper-responsive way, which is this right here, that hyper-responsiveness leads to an inflammation. The inflammation occurs here in this mucous membrane in the inside of the bronchioles. What happens on the outside part here is that it constricts. That's called the bronchioles kind of constrict. So it's twofold. You have inflammation within the middle part, and then you have bronchoconstriction around the outside of it. So that's why we try to treat with a bronchodilator and also an inhaled medication such as an inhaled steroid that can decrease that inflammation on the inside as well. That's why as we talk about medications that are utilized to treat asthma, we'll talk about combination medications such as inhalers that contain both a bronchodilator So it fixes this outside part, and then the medication will also have that anti-inflammatory steroid effect that decreases that inner mucous membrane inflammation. This is kind of the same picture that I just drew on that last slide. It's this is your normal interlumen of your bronchioles, that normal smooth muscle. This is an inside of a bronchial tube that has now had that hyperactivity to some kind of trigger that they've been exposed to, and now they have that increased secretion, mucus, inflammation, constriction of the bronchial smooth muscle. And it's all about that inflammatory response that we talked about when we talked about the immune response, causing this hypersensitivity to something that the body has identified as something it does not like, and so it causes this big immune response to it. Inflammation of the airways contributes to bronchial hyperactivity, airflow limitation. So remember that ventilation we talked about when they're trying to breathe in their oxygen? That's limited. And the resultant characteristic signs and symptoms of asthma, which is wheezing due to that constricted airway from broncho constriction and the inflammation. Breathlessness, chest tightness, and cough. The stage is then set for acute bronchoconstriction, airway edema. So you see the constriction, the edema, mucus plug formation. That's because we have this increased secretion of tenacious mucus, and that's that inflammatory response. And airway narrowing and bronchial obstruction. And this should make sense to all of you from what you know about what the respiratory system does. It's our airway. It's how we get oxygen to the tissue. And you can see how all of this process could be a problem for your patient as far as airway maintenance and gas exchange. Again, we kind of mentioned this in the last slide, but this is some assessment, some signs and symptoms of a patient with asthma. That audible wheeze is pretty hallmark sign of asthma, as acute asthma exacerbation. Of course, the increased respiratory rate, because they're going to have they're going to work harder. Now that they've got this constricted airway, they have to work harder because you got to pull in that oxygen, because your body still needs oxygen, so they've got to work hard to get that in there. The cough is secondary to that inflammatory response. Again, like I said, they're going to use those accessory muscles because now they've got a harder work of breathing to bring air in through those constrictive airways. Barrel chest from air trapping. This is usually somebody who has really had a hard time with their asthma. This isn't common in all of your asthmatics. Long breathing cycle. That's that inspiratory and expiratory phase. Think about this. If you have an inflamed, constricted airway, you're going to try to take a long breath in to try to get that oxygen in, and then they'll have a long expiratory phase as well because they're trying to blow out that CO2 in this restricted airway. Cyanosis, of course, we know is indicative of not getting enough oxygen. Cyanosis and hypoxemia. Hypoxemia means you have a low oxygen level in your blood, and that's as a result of not being able to pull in your oxygen as you need it because you have a constricted airway. This is some diagnostic information as far as diagnosing a patient with asthma. If you looked up the pathophysiology, and actually I'll read you a little bit of information on the pathophysiology of asthma. Asthma is a chronic inflammatory disease associated by reversible hyperreactivity of the bronchi and the bronchioles to a variety of stimuli. What occurs in response to this stimuli is an inflammation that is the major pathologic mechanism of this disease. So remember when we talked about that immune response? Your body sends in eosinophils, lymphocytes, neutrophils, and macrophages. They maybe directly infiltrate into the airway due to that inflammatory immune response. So that makes sense with these diagnostic tests here, like the sputum with eosinophils, because that's that immune response that's coming in to try to attack something that it's identifying as foreign that we're breathing into our body. Pulmonary function testing is the hallmark of diagnosing asthma. Pulmonary function testing is when we take a patient into a booth, into a special little area, and do some breathing tests with them. Okay, pulmonary function tests can measure either volume or capacity. So volume means how much we can breathe in or how much we can blow out. Capacity is kind of the similar. Some pulmonary capacity tests must be calculated. And this is something that happens, like I said, by very highly trained people in a lab that do this pulmonary function testing. But it is the hallmark of diagnosing asthma and COPD, actually, because really what we're determining is the patient's ability to their volumes and their capacity of their lungs right now. So the person orders the test to evaluate ventilatory function through spirometry. Spirometry is measurements. It's a piece of pulmonary function testing. Spirometry is. It can help to assess the effectiveness of medications such as bronchodilators and steroids. Oftentimes, a patient, we will do a pulmonary function test, and then we'll give them medication. We'll have them either do like an inhaler or do an inhaled nebulizer, which is a medication that they inhale, and then do the test again, do the pulmonary function test again. And that helps us determine if they have, what their numbers are prior to the medication and then after the medication. So that helps us determine if a medication is effective in helping their volumes. Pulmonary function testing is also utilized to evaluate the extent of any dysfunction that they have. So it can tell us how bad their lung function is or how good it is. At this point, we don't need to know how to interpret these results or anything. The main thing is to know that pulmonary function is really the best way to diagnose a patient with asthma or COPD. And these are things: forced vital capacity, forced expiratory volume, and peak expiratory flow rate. And that's they have the patient they blow into a certain little piece of machinery, and it can calculate exactly how much volume they can blow out, how much they can, when they take a deep breath in, how much they can pull in. And so it kind of helps us determine the extent of a patient's pulmonary function. And then, like I said, sometimes they'll give them a medicine and see if that makes it better. So it's one of those things where it gives us accurate data so we can look at numbers in order to diagnose a patient rather than just kind of that subjective assessment and that objective assessment. These are numbers that support our objective assessment. So pulmonary function testing is a great way to diagnose a patient, and then it's also a great way to kind of manage a patient. So if a patient feels like they're not getting better, maybe they're getting worse, we'll bring them back in. Let's do some spirometry test and see indeed if you are getting worse or if your numbers are the same or if your numbers maybe are better, things like that. It helps us to evaluate a patient. Okay, moving on to treatment of asthma. Teaching a patient about self-management is so important with asthma. It starts with being able to identify what the triggers are for a patient with asthma, and they need to avoid those triggers at all costs if they can. Sometimes it's difficult. Sometimes if it's exercise-induced asthma, sometimes exercise is kind of like a stressor that will cause that reactive airway. We'll go ahead and pre-medicate them. So sometimes those patients will go ahead and take some medications prior to exercise because we've identified that exercise is that trigger for them. Patients around, if pets is their trigger, they need to really try to stay away from pets the best they can. Stress, if stress is their trigger, try to avoid it. Not always easy, but it's really something they can attempt to do. and it's important to identify those triggers so that we can treat them a little bit more effectively. Daily monitoring of peak expiratory flow. This is a peak expiratory flow is sort of like a pulmonary function test or spirometry test that they can kind of do at home. It's like a little mini pulmonary function test that they can do at home. It can give them a number. They can have a goal. It's encouraged that they do it twice a day, and their numbers should be around, I don't know the exact numbers of what a peak flow meter usually tells them, but basically they're given like a goal of where they want to be by their individual physician, and they want to check it. So it's almost like checking your blood sugar. It's crazy, but it kind of is. So the peak flow numbers help a patient to determine whether they're kind of in a therapeutic range or not. If their numbers become worse, they know that maybe they need to call their physician. Maybe they need to take an extra dose of their medication, something like that. It's sort of that teaching of self-management that makes a patient feel better and be able to kind of control their own management and hopefully keep them out of the hospital by doing these types of things. Every patient is on their own personal drug therapy plan because everybody has different triggers. Everybody has different medications that are effective for them. And so it's important to make sure that we educate them regarding their medications. Controller medications are very important. We're finding that long-acting bronchodilators are very effective. Albuterol is a short-acting bronchodilator, and that's typically in this range here of the rescue drugs. Like I said, that is a short-acting bronchodilator. It is known as the rescue drug. We have long-acting bronchodilators that they're long-term, so they're more of a maintenance medication as opposed to your rescue drug. Your book has a good table that kind of helps you differentiate between the long-acting and short-acting bronchodilators. And it seems like every day they're coming out with a new inhaler because we're getting really good at kind of producing these good maintenance drug inhalers for patients with asthma and COPD. Long-acting, one is salmeterol, which is also known as Ceravent. That's a long-acting bronchodilator. So it kind of keeps the patient, their bronchioles dilated for a long period of time as opposed to your albuterol, which again is kind of short-acting. Again, we're kind of like, if you think about this in relation to diabetes, your short acting's for your little spike in your blood sugar, and then your long one is to kind of keep you maintained for a long period of time. So it's kind of the same concept. So there's also some different types of anti-inflammatory inhalers, and they are corticosteroids. So essentially we have drugs that treat that bronchodilation, and then we have drugs that treat that like mucous membrane inflammation kind of on the inside there. That's an inhaled steroid. The beauty of these is that it does not have that systemic effect on the patient. Typically, it's just kind of a steroid that is inhaled down into the bronchioles and treats it right there. And remember, talking about in Module 7 about the effects of oral steroids that can cause a systemic effects and side effects and things like that and complications in a patient. So these inhaled steroids can just act within the lungs and decrease that inflammation that's occurring in there. Fluticasone, I can't even say these. Flovent is the brand name of a very common inhaled steroid. And usually they're kind of, the name of them, the generic one is, so prednisone we know is a steroid, and so a lot of the inhaled steroids end in SONE as well. So fluticasone is one of them, and you'll find that a lot of them end in that SONE. There's another drug that a patient may take, and this has made a lot of difference in the treatment of patients with asthma. It's called leukotriene modifier. And essentially what this does, remember we talked about that, inflammatory immune response that occurs when a patient with asthma is exposed to their triggers. This blocks that leukotriene receptor, preventing the inflammatory mediator from stimulating that inflammation. That medication is called montelukast, otherwise known as Singulair as the brand name. It's a pill that they take on a daily basis. The purpose is to prevent asthma attack triggered by inflammation or allergens. So that drug has been very, very effective in a maintenance drug for patients with asthma. This is just kind of repeating some of the stuff that I talked about on the last slide. Short-acting bronchodilator, I'm going to write it again so you don't forget it, is known as albuterol. Albuterol is the rescue inhaler. Always, 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 because it's a short-acting. So this is what we give a patient when they come into the ER and they are stridorous. Remember that term stridorous? It's when they're like that real high-pitched noise where you can tell that their airway is very constricted. We're going to give them rescue albuterol. It is a fast-acting bronchodilator. And then you have those long-acting bronchodilators. Like we said, Ceravent is one of them. That's your maintenance medication. Cholinergic antagonists are also bronchodilators. And they kind of act in a little bit different way. That is known as ipratropium, and that is Atrovent. Sometimes a patient would be put on, while they're hospitalized for an asthma exacerbation, we'll put them on something called a duoneb, and it is albuterol and Atrovent together. Or, I gotta say this right, ipratropium. And those are two bronchodilators that work in a little bit different way. They're short-acting, and like I said, they work in a little bit different way. The cholinergic antagonist causes bronchodilation by inhibiting the parasympathetic nervous system. So they kind of work with the sympathetic nervous system. Bottom line here really is that we have to educate our patients about the proper use of inhaled medications. There is a proper way to use it, and there is instructions listed in your book on how to use an inhaler correctly. That's sometimes a challenge with some patients. A spacer is sometimes provided, and what the spacer does is allow the patient to, when they shake the inhaler up, they give it a little puff, and then the spacer keeps the medication in there until the patient is able to take a deep breath in. And the real bottom line here is that they have to take a deep breath in and hold it, and keep that in their lungs and let that medication get down into their lungs. So, like I said, in your book, you have lots of different tables about teaching a patient. I highly encourage you to make sure you look that over so that you are able to teach a patient about how to do an inhaler. And I'm going to bring some supplies to class, and we're going to talk about this in class about the proper use of an inhaler as well. One last thing about asthma. So, like we said earlier on in the introduction about asthma, is it can become a life-threatening situation due to the very acute effects of the bronchoconstriction and the inflammatory response. It could actually completely constrict an airway. Status asthmaticus is a severe, life-threatening, acute episode of airway obstruction. It intensifies once it begins and often does not respond to usual therapy. So this is kind of like your super, super bad asthma attack. Patient arrives in the ED, extremely labored breathing and wheezing. That's that stridor, when you hear that high-pitched whistling sound outside the door. You don't even have to use your stethoscope. That is a patient who's having a severe asthma attack, status asthmaticus. They're using accessory muscles for breathing. If it is not reversed, the patient can go into a cardiac or respiratory arrest. So we are using those bronchodilators, steroids, epinephrine sometimes as a rescue medication. So really what you need to know here is that status asthmaticus is a patient who is having a severe asthma attack and that it can be a life-threatening situation. Our drug of choice is that rescue inhaler, which is albuterol. That's what we need to give them. That's our short-acting bronchodilator. We need to open the airway. Sometimes epinephrine is what we need to use to assist us with opening that airway. For the second half of the presentation for Module 8, we will discuss chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is sort of an umbrella term. It refers to emphysema and or chronic bronchitis. It is more commonly a combination of these two conditions. COPD is one of the most common chronic lung diseases. It affects about 30 million Americans. Its incidence is rising. It now ranks 4th among the major causes of death in the United States. The causes of COPD include cigarette smoking, recurrent or chronic respiratory tract infections, allergies, and some familial and hereditary factors. Some occupational exposures, environmental exposures can lead to a COPD as well. Smoking is one of the major causes, and this is due to the impaired ciliary action and macrophage function that causes inflammation in the airways. This is related to every time a person inhales off of a cigarette, your body kind of identifies it as an irritant and as foreign, and it kind of goes into a little bit of a inflammatory process. So it sends in macrophages and causes inflammation in the airways. This causes increased mucus production and destruction of the alveolar septa. Each inflammatory changes may reverse if the patient stops smoking before the lung disease becomes extensive. So typically this chronic inflammation due to this continued exposure to some kind of an irritant, that's essentially what is caused the symptoms of the chronic bronchitis. So bronchitis means inflammation of the bronchioles, and this becomes chronic over time after exposures to cigarette smoke or other kind of irritants in the environment. The mucus plugs get in narrowed, trapped airways as a result. And then eventually the alveoli get hyperinflated on expiration. And so the emphysema, the term emphysema is discussing, it is kind of when indicates the alveoli damage. So just in summary, chronic bronchitis is a chronic inflammation of the bronchioles, and then the emphysema is referring to the damaged alveoli that hyperinflate and trap air. So this becomes a problem. The chronic bronchitis becomes a problem with ventilation, so getting air in. Once air is in, the alveoli expand with inspiration, but they narrow on expiration, preventing gas flow. So air trapping occurs, and that determines that the patient has poor gas exchange at the alveolar level. So the problem becomes an ventilation problem along with a gas exchange problem. The big difference in differentiating this between COPD and asthma is the fact that this is not reversible. It increases in severity and eventually leads to a respiratory failure, especially in a patient if it's caused by smoking and they continue to smoke. The two major changes that occur with emphysema are the loss of lung elasticity and hyperinflation of the lung. These changes result in difficulty in breathing and the need for an increased respiratory rate. So basically the gas exchange is difficult, and the patient has this loss of lung elasticity. So it makes breathing more difficult, and they have to work harder in order to ventilate and have successful gas exchange. Air trapping is a common term that you'll hear when referring to emphysema. It means that there's an increased amount of air trapped in the lungs. Causes of air trapping are loss of elastic recoil in the alveolar walls, overstretching and enlargement of the alveoli into an air-filled space called a bullae, and the collapse of the small bronchioles. So it's just really causes poor recoil in the alveolar. If you looked at the normal anatomy and physiology of how the alveoli sacs expand when we're taking in a breath, a person with emphysema, theirs is not working correctly because of the loss of the elasticity. This results in the use of accessory muscles in the neck, chest wall, and abdomen to inhale and exhale. They have to work harder to get their ventilation and gas exchange successful. The increased effort increases the need for oxygen, making the patient kind of have this chronic air hunger feeling. They begin to have an uncoordinated breathing pattern, and this is because of inhalation can start before exhalation is completed, because their respiratory rate is so rapid and they're fighting so hard to get their breath. This is just a slide to kind of compare and contrast and identify how chronic bronchitis and pulmonary emphysema are together under the umbrella term of chronic obstructive pulmonary disease. And kind of like I said in the slides before, chronic bronchitis is more of an airway problem, and then pulmonary emphysema is more at the alveolar level. And these are both brought on by the toxic exposure to cigarette smoke typically, and maybe some other environmental exposure as well, but typically it's cigarette smoke causes the airway problem because of the chronic inflammation in the bronchioles, and then it also damages it at the alveolar level as well. And I kind of said most of this already about what chronic bronchitis is. It's inflammation of the bronchi, and the bronchioles caused by chronic exposure, typically cigarette smoke. It's inflammation, vasodilation, congestion, and a lot of it is this large amount of thick mucus. And remember, I said that ciliary, in your respiratory tract, you have these little hair-like things that help to propel the mucus out, because we want to get mucus out of the body. Thick mucus is a perfect little medium for bacteria to grow in. And so this chronic bronchitis with this poor ciliary action, thick mucus, they are at high risk for developing a pneumonia, because a lot of times the bacteria sit within this mucus. They have poor ciliary action that helps propel the mucus out. They have a weak cough. They have an increased work of breathing. So they are at really big risk for getting pneumonia, and it's really hard for them to recover from getting a pneumonia. This is just a quote. There's some professional organizations that work specifically with respiratory diseases, and the gold standard is some standards that were put out in the past 10 years regarding standards for COPD treatment, and this is just a quote from those specialists. It says COPD is too often dismissed as self-inflicted disease of the old, when it needs to be thought of as a condition that is global. The reason they put this out here is because it is like I said in the numbers, there's a huge number of patients who are affected with COPD. It's an expensive disease to control, and a lot of times leads to many hospitalizations that we need to try to help prevent people from getting this disease, and we also need to help make sure that they are managed appropriately in order to keep them out of the hospital. I think we already talked about this, mostly about cigarette smoking being the greatest risk factor for COPD, and that it's just a reminder that inhaled smoke triggers the release of excessive amounts of proteases from the cells in the lungs. Essentially what that is that inflammatory response, that immune response to something that your body has identified as foreign. Passive smoking, don't forget about secondhand smoke. And then thirdhand smoke is also that smell that remains in people's hair and clothing when you're in a room with people who smoke. They can all contribute to respiratory problems. So it's not just people who smoke, but it's also people who are around smokers a lot. This is just a visual reminder of all the things that are risk factors for a COPD problem, and I think we already listed most of these: the air pollution, exposure to secondary smoke, any kind of a person who has maybe an already chronic respiratory problem. It can be genetics, and it can be occupational exposures. As far as occupational exposures, whoever is running a place that like a coal mine perhaps, they need to make sure that their workers are protected, and that would be wearing a mask maybe that prevents them from inhaling something in the air that could be toxic to them. Maybe some kind of a like we sort of wear the special mask for when we're in a room with a patient with TB to prevent us from being exposed to that. It's, some kind of a special protective device needs to be provided by the employer to make sure that the workers are not getting a chronic disease from working in that type of environment. This slide is really just reminding you of the things that we've already spoke about. It's sort of more of a visual picture of the definition of COPD. The airways and air sacs lose their elastic quality. As you can see, this is a healthy alveoli. This is where they become less elastic and they're just kind of like droopy almost. And then the walls between many of the air sacs are destroyed. And you can see the difference here. Here's a healthy bronchiole, and here's when it becomes inflamed and has a lot of excess mucus in it. So that, again, like I said, this is sort of a visual of what happens with COPD within the lungs. This slide I got from respiratory therapy at the hospital, and it's just talking about early diagnosis of COPD is very important. Lung damage starts early and is progressive. So basically, it's sort of like a lot of the other disorders that we talk about. The quicker you find it, and the more quickly that you treat it, the less damage is going to hopefully occur, and hopefully the outcome for the patient is better. It's important that we identify it early, and then we can begin talking to patients who smoke about possibly not smoking. We can talk to them that they already are showing maybe signs and symptoms of COPD, and that stopping smoking could be their number one way of stopping it from getting any worse. Smoking cessation is sometimes a tricky subject with patients. We have to present it in a non-judgmental way, and really present it in the way that a factual way that tells them that there's studies that show that their cigarette smoke is probably causing their symptoms, and there's studies that show that if they stop now, they could actually live a good, healthy life. So you present it in a non-judgmental way, more of a factual way. The other thing is just asking the patient and giving them choices and letting them make the choice when they stop smoking usually is a more effective way of getting a person to stop smoking. And we just talk to them each time that we see them. Are you ready to quit smoking yet? If they say no, we'll say, you let me know when you're ready to quit, and I'll help you. If you say, are you ready to quit smoking? And they say yes, well, then we will put everything in place to help them, and we will give them choices and let them choose which intervention they would like to do in order to quit smoking. This is just sort of a process utilized in order to diagnose COPD, and this is just bringing in that spirometry, which is that pulmonary function test that allows us to get numbers in order to have specific data to support the diagnosis of COPD. And remember, spirometry is the gold standard for diagnosing COPD. So basically, if a patient presents with chronic symptoms, this chronic cough, chronic productive cough, and shortness of breath, check. Okay, you could possibly have COPD. And then we ask them, do you smoke? Are you in an occupation that exposes you to an irritant? Check. Maybe they are a smoker. Okay. Now we're going to send you to do spirometry to confirm the diagnosis of COPD. Here's some numbers here. You don't have to know that. This is forced expired volume and things like that. Respiratory therapy and the pulmonologist will take care of these numbers. But basically what we need to know is that the third step would be to definitively diagnose a patient with COPD is to do that spirometry. And we can monitor those numbers. So very similar to what we look at in asthma. It's kind of a way of just checking on them. It's sort of our blood sugar check to see that A1C. It's sort of, we can do an A1C on a diabetic to check and see how they're coming along. These numbers do the same thing for us when we talk about a COPD patient. This information I also got from respiratory therapy. It just talks about why spirometry is essential for the diagnosis and severity of staging. Gold guidelines, again, these are recommendations from pulmonologists that put together recommendations for proper diagnosis and treatment of patients with COPD. Because what happens a lot of times is people are not identified accurately and they're not treated accurately, and then their symptoms get worse, and then they end up in the hospital and they're just not managed well. So pulmonologists across the country put out these gold guidelines and said we have to do this in a very consistent manner in order to treat people appropriately and make sure that they get the proper treatment. So the gold guidelines said COPD patients using spirometry to determine the stage of their disease, and then medications and treatment modalities are described based on their stage. So again, like I was just saying, these are ways that we can accurately, consistently, and in an organized manner treat a patient for where they are, and treat their symptoms appropriately and hopefully keep them out of the hospital. Again, I'm going to kind of compare it to like diabetes. Like we base our treatment for diabetic patients based on what their blood sugars are looking like. If their blood sugars are running higher, we're going to give them more insulin. So this is sort of how the spirometry helps us to manage a COPD patient. Evidence shows that without proper staging, COPD is impossible to effectively manage. So this slide, I just wanted to make sure you understand this, and this can help you as you educate patients about this disease process, because you're going to encounter a patient with COPD in your practice. So it's important that you know that there are guidelines to help us manage them appropriately. I think we've mentioned a lot of these. We'll just kind of review them again. They help in the diagnosis of COPD. Arterial blood gases. Basically, it's just important that you know that is an arterial blood sample. Most of the blood samples that we get to check like basic labs is just a venous draw. Arterial blood, the arteries is what carries blood oxygenated blood away from the heart. So if we checked a sample of arterial blood, we can look at specific oxygenation. So let's kind of go back here and kind of review. The lungs oxygenate your blood. So your blood goes from the right side of the heart to your lungs to become oxygenated, and then they go back into the heart on the left side, and then the left side of the heart pumps out this oxygenated blood. So when we get that artery sample, it's kind of showing us how well those lungs were able to oxygenate the blood. And so that's why it gives us a good picture of how well the lungs are working. Sputum samples, we know that we can just have them give us in a sterile cup, give us some sputum sample so we can test it for any bacteria. We'll do a culture and sensitivity. If we find that there's a specific germ in there, we'll treat it with the appropriate antibiotic. CBC, that tells us a lot about a patient. Are they anemic? Are they have an infectious process? If their white blood cells are elevated, things like that. We know that the hematocrit and hemoglobin. We know that hemoglobin would be very directly related to our oxygenation status, so that's a good key for us to help us identify what's going on with the patient. Serum electrolytes, that tells us hydration. It tells us, if the kidneys are functioning well. Lots of different things like that. Chest x-ray, it's a picture of that chest. We can look at the lungs to be able to identify, if we see any kind of fluid in there, any lesions, any abnormalities in the anatomic position of the lungs, things like that. Pulmonary function testing I pretty much covered in the past few slides. We know that that is the gold standard. And make sure that you understand that spirometry is a form of a pulmonary function test, so they sort of go together. Priority nursing care for a patient with COPD. Number one here, we have to improve their oxygenation and reduce carbon dioxide retention. Think about your interventions for that. Of course, that is a lot of times it's their positioning, making sure that they're sitting up, they're comfortable. That helps improve ventilation. Reduce carbon dioxide retention. There's an intervention that we know of called pursed-lipped breathing. Pursed-lipped breathing is a way to slow down a person's breathing so they breathe in their nose, out their mouth with pursed lips. That helps them to improve their oxygenation and reduce carbon dioxide retention. It's an organized way to breathe in and breathe out. Pursed lip breathing. I think in the past few slides I spoke about how their respirations get very disorganized, and sometimes their exhalation starts before their at the same time their inhalation starts, so it's very unorganized. So this pursed lip breathing is a way to slow that down and make sure that they get improved oxygen and reduce their carbon dioxide retention. A lot of times they have a lot of weight loss because of the work of breathing. It takes a lot of calories over time. If someone is fighting and fighting and fighting to get their self oxygenated, and it can increase their metabolism and require a lot of calories. Minimize anxiety. Of course, because anytime we have stress or we're anxious, it makes us breathe heavier, makes us work heavier. So we have to keep them calm. Think of all your nursing interventions to do that. A calm environment. Make sure they don't have too many visitors, especially if it's visitors that makes them anxious. Kind of try to help control that kind of things. Teach them therapeutic calming techniques. Maybe it's turning on some soft music on the television, turning the lights down, helping them to do maybe some meditation techniques and things like that. Helping them with their activity intolerance, make sure you're not going to schedule them 20 activities in a 2-hour period. They're not going to be able to tolerate that. So make sure you kind of think of ways to help their activity tolerance and prevent respiratory infection. You know how to do that. We've talked about that the whole way in Nursing 150 so far. You do make sure that they're mobile to as much as they can tolerate. We help them to be mobile by giving them devices that can help them continue to be mobile. IS, your incentive spirometer, is such a key feature in preventing infection. Your incentive spirometer, which helps you to cough and deep breathe. Sorry, it's not coming out very well. That's a key factor in this prevention of infection. Keep them away from sick people. And things like that. So very, very imperative in a patient with COPD. Like I said in one of the earlier slides, a patient with COPD is such high risk for getting pneumonia due to that chronic bronchitis aspect of it, because of all that thick mucus that's sitting in there, and they're having difficulty coughing it out due to the inflamed airways. So make sure we keep them away from sick people and keep them to cough and deep breathe to get that mucus out of there. And this is some nursing interventions kind of related to the problems that we just spoke of. And that's a lot of times you have to provide them 4 to 6 small meals, small being a key word here, because they have a high calorie need. However, think about how you feel if you eat a large meal. A large meal actually takes some room up in your thoracic cavity there. and can make the work of breathing even more difficult. So they need lots of calories, but in small doses, so that it doesn't cause them to be more short of breath. So again, this is another slide that I got from a respiratory therapist regarding treatment of a patient with COPD. They have a lot of trouble with patients being changed and not being kept on their COPD medications. Perhaps they're brought into the hospital for another reason, and then maybe their COPD medication management gets kind of skewed a little bit. So it's important that we try to keep them on track and make sure that we keep them on the meds that they were on, especially if it's being effective for them. Because again, if we put them in the hospital and then we don't keep them on their treatment for COPD, they could end up with a whole nother problem as far as their management of their COPD. These medications are used to control the symptoms, because remember, COPD is irreversible lung damage. But we have lots of medications that are very effective if used appropriately in decreasing the symptoms and controlling the symptoms. Some of these medications are the same medications that we use with asthma. So because they do the same effectiveness. Bronchodilators we talked about with asthma, that increases the airflow by opening those airways. And remember that's where it kind of opens those bronchioles. And then the corticosteroids reduce inflammation. They're either inhaled with an inhaler or taken by mouth. And like I said, they're trying to get more patients to be on an inhaled steroid because it doesn't have the systemic effects. And remember, the inside of the bronchiole here, that's where the inflammation is. So if we use a bronchodilator with a corticosteroid, we open up this airway and then we decrease this inflammation in here. And by doing that, we hopefully decrease the resistance of inhalation and exhalation. Leukotriene modifiers we talked about with asthma as well. That's your Singulair is one of them, and they help by preventing this inflammatory response. Remember that Luke, that L-E-U-K, is referring to a white blood cell. Remember how the inflammatory response sends in all these eosinophils and white blood cells that causes the inflammation to the area. So these are a pill usually, and a patient takes that every day as maintenance to prevent this inflammatory response from happening. Of course, we've got antibiotics to treat a patient who's been identified as having a bacterial infection. Some of the common ones for respiratory is Zithromax, which is a lot of us know it as a Z-Pak. And that's a common antibiotic that's utilized for the common bacteria found in the lungs. Combination therapy, taking an inhaled steroid and a bronchodilator together is an effective treatment. So this is the latest and greatest. We have inhalers now that have both bronchodilators and corticosteroids in them, which has been very effective in the treatment of COPD. The names of some of those combination inhalers is fluticasone and salmeterol, and that is commercially known as Advair. We also have ipratropium and albuterol, which is that's a combination of two bronchodilators. The important thing to understand, again, like I said when I was talking about the inhalers with asthma, a patient has to be able to use an inhaler properly, and they have to be educated on how to use it so that it's effective. Another thing about the inhaled steroids. So remember, talking about steroids, they kind of increase inflammation, and also by doing that, they kind of decrease the immune response. So super infections in the mouth can occur with an inhaled steroid. So think about it, they're putting steroids into their oral cavity, which decreases inflammation and decreases the immune response. This can put them at risk for getting like a thrush, which is like a fungal infection in their mouth. So it's important that you educate a patient to rinse their mouth out after they use a steroid inhaler, and that should prevent this from occurring. This is how a lot of pulmonologists teach their patients to take a steroid inhaler. They will tell them, and usually they're like once a day. It's a maintenance drug that they just take once a day. So they'll tell them to take their inhaler and put it in the bathroom by their toothbrush. So what they do is when they get up in the morning, they take their inhaler. So do that properly, use the proper function. And we'll talk about this in class, exactly how to properly do an inhaler. So they do their inhaler in the morning, and then after that, they brush their teeth, rinse their mouth out. It's a good practice so that they remember to take their inhaler, and they remember to rinse their mouth out after they do it. So it's just a good practice and a good habit to teach a patient to do. This is just a slide that kind of talks about the difference between a maintenance and controller medications as opposed to a rescue. The maintenance and controller medications are usually something that a patient takes once a day. It's long-acting medication. That is their maintenance med. They last longer and provide a very steady delivery of the medication over a long period of time. So this is an important sentence here. They also should have a rescue inhaler, and this is if something triggers them and gets them in trouble. And usually it's an albuterol. Albuterol is a short-acting bronchodilator. That is their rescue med. So, and a lot of times they are told that if you are using your rescue inhaler more than once a week, once a day, it depends on the patient. If you're using your rescue inhaler a lot, this one is not working. So we need to reevaluate the maintenance one. So the idea behind the rescue inhaler is that it should not be used very often. If they notice that they're using it a lot, that should be an indicator that maybe something needs to be changed in their maintenance inhalers. And we'll talk about this a little bit more in class, but it's just a good idea to have a understanding of the difference between a maintenance medication and the rescue inhaler for a patient with COPD. And this goes for asthma as well. This is just some pictures of those inhalers. And as you can tell by looking at them, they can be a little bit complicated to use, so it's important that the patient is educated properly on how to utilize them. Again, another slide to kind of differentiate between that maintenance medication and those as needed or emergency ones. And these are just some pictures of some albuterol inhalers. And as you can see, there are so many different kinds of them. It can be very confusing to a patient. So it's important that we educate them about it. A lot of times they don't know what they're called, but if you show them a picture of it, I'd be able to identify it. And I've seen nurses and respiratory therapists utilize this tactic to try to figure out what kind of inhaler a patient's on. Because like I said, a lot of times they don't know what it is. They just know what color it is. This is just an example of a maintenance plan for a patient with COPD. This is what's used by the Christ Hospital Health Network. You might see other facilities use a different type of a maintenance program, but it's kind of a teaching tool for your patient. They basically tell them to check themselves every day. So are they in the green zone? Are they in the yellow zone? Or are they in the red zone? So, it's hard to see here, but if you see the criteria here, this is, if they're doing all of this, that means they're all clear and they're good to go. That means if they're breathing normal, no changes in their mucus, no tightness in their chest, they have minimal fatigue, no swollen ankles, their appetite is good, and they're sleeping well at night, they're good to go. That means their medication is working. However, if the next day they get up and they see some changes and they meet this criteria here in the yellow zone, if they find themselves in the yellow zone, then they have things that they need to do. These are recommendations. Get plenty of rest, relaxation, use quick relief inhaler, use oxygen, call provider if symptoms don't improve. So it's a way of self-maintenance. And then you can see here, if a patient finds themselves in the red zone, so this means they're getting worse. They're having chest pain, they're having fever, confused, then they need to call their doctor right away. This method is being implemented for COPD patients as well as asthma patients What this does is it helps a patient sort of assess themselves and do the proper intervention so that they are managed properly, and that they get their, like if they're in the yellow zone, they get help there before they get to the red zone. So it's just a self-management, self-assessment to help a patient become a part of properly treating their condition. The community is very much a partner in treating patients with COPD. I know a lot of the, this is just example of some of the partners that the Christ Hospital Health Network has. And basically, we don't just send people home without any help. We send them to places that they can receive continued support for their chronic condition. This is just kind of a summary of all the patient education that's required for a COPD patient. Long-term use of oxygen may be indicated. If that is so, then we need to help them make sure that that gets facilitated. Pulmonary rehab is, that is a kind of an outpatient thing that can be utilized, and basically the people might go to a pulmonary rehab 3 times a week, and they help them with activity, they help them manage their illness, and basically they help with smoking cessation, lots of different things like that. Teaching for self-management, we kind of went over all of that stuff. These are all interventions that we can teach a patient to help them manage their COPD. We already talked some about occupational pulmonary disease. These are pulmonary diseases that are caused by exposure in the environment and their occupation, fumes, dust, vapors, gases, things like that. Of course, if they're a smoker, it's only going to make it worse. And so, like I said earlier, this is the key to prevention of that. If a patient is working at a place where they're getting pulmonary problems, they need to make sure that their employer is providing them with proper respirators and adequate ventilation. If not, they can complain through OSHA, which is an organization that can come in and make sure it's occupational safety, health. I forget exactly what OSHA stands for, but it's something that needs to be provided for them from the employer. Or the employer can get in trouble if they're not supplying the proper preventive devices for the employees. The following slides are questions and case studies to assess your learning regarding COPD and asthma. I encourage you to complete these and check your answers that are posted in the comment section in the PowerPoint. I look forward to discussing these disorders with you in class. This concludes a presentation for Module 8 for Nursing 150 regarding COPD and asthma.